Okay, everybody, good morning. Good morning. Welcome back to the second installment of Graduating Fellows Grand Rounds. We will make our best effort to start on time, so we'll get going. Before I introduce our first esteemed speaker, the standard housekeeping stuff to remind everybody of. This is being video conferenced and videotaped, so when it comes to the question period, please use the microphones. That's probably it. Remember to subscribe to our YouTube channel. You'll see all of this on that channel as well. So if you have to leave early, you can finish up on YouTube. Our next conference is tomorrow, VASA, which is Vascular Access Society of the Americas, hands-on practicum on hemodialysis access. So if you're so inclined, Jennifer can give you some details on that for tomorrow. So without further ado, it's my pleasure to introduce Dr. Paul Karagiannis, who's a third-year fellow here. A little background on Paul. He did undergrad at Northwestern, medical school at University of Illinois, internal medicine at University of Minnesota. Here obviously for the last 3 years in cardiology. Interests in heart failure, CT, echo. And we're very excited because Paul is going to go to Piedmont Heart in Atlanta and start his independent career in just a couple of months in July. So without further ado, Paul's going to talk to us about the topic of his choice. All yours, Paul.
Thank you, everyone. Thanks for coming. I'll be talking today about LVAD Hemodynamics. So learning objectives for today, I want to provide some kind of an interesting framework for understanding LVAD hemodynamics, maybe something that not all of us are familiar with. And just to start, we'll go with a quick introduction to LVADs. So a lot of people walk into to LVADs with some misconceptions. Some folks approach them as being a very kind of complicated device that's too difficult to understand. You check it out from across the room and you want nothing to do with it. Some people have the opposite opinion. Some people are just feel that it's a fairly uncomplicated device. You turn it on, you walk away, and let it work, let it spin. So the important thing to take away is that the LVAD is a very, very complicated, sophisticated machine, and there's a very unique patient-pump interaction that exists. Some papers actually refer to it as a hemodynamic fingerprint that depends partly on several patient factors: their preoperative RV function, what the native contractility is, what the patient's afterload is, and what type of medications they happen to be on. So we are currently in the continuous flow era. LVAD started out, a lot of their history actually belongs in Houston, and we've moved from the pulsatile era to the continuous flow era. There are two types of pumps available. There are axial pumps such as the HeartMate 2, and centrifugal pumps such as the HeartMate 3 and the HeartWare HVAD. We're all very familiar with the results of the very, very important clinical trials. They improve mortality, they improve quality of life, and they're becoming more and more prevalent. So there's been 20,000 implanted as of this past January, and they're going to become more and more prevalent in the future. These pumps will be in your ERs. These VAD patients will be in your CCU, and we will be reading their echoes in the years to come. So it behooves us to become a little bit more familiar with the hemodynamics. Just a quick primer on VAD anatomy. So on the left, we see an axial flow VAD. It happens to be HeartMate 2, and the working parts for our discussion here include the inflow cannula that's positioned here at the apex of the heart that draws blood through the pump. The pump imparts kinetic energy to the blood and delivers it into the ascending aorta through the outflow graft. On the right is a centrifugal pump, similar design. Inflow cannula at the apex pulls blood through and pushes it into the ascending aorta. The important difference is that the axial flow pump, the direction of blood in entering the pump and leaving the pump is on a single axis, whereas in the centrifugal flow pumps, the blood exits the pump perpendicular to the direction of blood inflow. This is the very, very familiar HeartMate 2 VAD console, familiar to us as fellows, perhaps a little less familiar to other members of the care team. So the important variables here are the pump flow, pump speed, pulse index, and pulse power. And we're going to work to try to understand these a little bit better as we go. So, and this is just a quick snapshot of kind of normal operating hemodynamic parameters for the VADs. To get into the meat of the discussion, we're going to start out with HQ curves. And HQ curves are going to be the dominant, the governing principle for LVAD flow and ultimately LVAD function. So VADs, as we know, are parallel circuits to the native LV. The VAD and the native LV compete for the same preload. The difference, though, is that the VAD is continually working. It's continually transferring blood from the LV into the aorta, irrespective of the cardiac cycle. So it's asynchronous to the cardiac cycle. What we'll notice, though, later on is that there is a mild coupling that can happen between the cardiac cycle and the pump itself. But ultimately, one of the important takeaways is the fact that VAD flow is continuous, not constant. And it's governed by two very important variables. One is the pump speed. The other one is actually the difference in pressure between the inflow and the outflow cannula, what's called delta P, or pump head pressure, pump or a pressure differential. So again, HQ curves are the guiding principle. It behooves us to kind of get this vocabulary, get more familiar with this vocabulary, because it really is the best way to understand pump function. So this is just a stylized pump. We have an inflow cannula on the right here, directing blood flow into the pump, and a outflow graft that delivers the blood flow into the aorta. You can imagine that there is a pressure present in the inflow cannula, denoted here as inflow pressure, and a pressure in the outflow cannula, the outflow pressure. If you wanted to analogize these to pump preload in the inflow and pump afterload in the outflow, that would be a good analogy to make. Ultimately, though, the pump is agnostic to the relative pressures themselves in the outflow and the inflow. What matters is the difference in pressure, the absolute pressure difference. So if we wanted to analogize the afterload as the map, say I have a map of 80 and a mean LV or preload of 20, all that matters to the pump is the 60. And it's this pressure differential that's going to be driving the flow through the pump. This is our first HQ curve. This is, again, a stylized HQ curve. We'll see a real HQ curve in just a few moments. This is the relationship between differential pressure, the H, and Q, which is the physics variable for flow in liters per minute. You can see here that there's an inverse relationship between differential pressure and flow. The greater the pressure difference across the pump, the lower the flow is. An important thing is that the HQ curves are unique to each pump, depending on the characteristics of the pumps themselves, the impeller shape, the angles, the dimensions of the pump, helps inform or determines the shape of the HQ curve. The other thing that's important to realize is that the HQ curves are actually a family of curves. The curves change depending on the RPM of the RPM setting of the VAD. So here we have three different curves, curve at 8600 all the way to 9600. And you can see that at 8600, the curve is steeper. There's a steeper relationship between delta P, the pressure differential, and flow. One way to interrogate this is to realize that at a constant pressure differential, at a constant delta P, here represented by the red dot, if you were to keep that pressure differential constant and just increase the VAD RPM, you're going to be getting a remarkably increased flow. So keeping the preload and afterload constant, turning up the VAD will increase the VAD flow. That's fairly intuitive, I think. It's an important first concept. These are the HQ curves themselves. This is from a paper from the Dr. Roderman's. These are the actual HQ curves, the heart MA2 on the left and the heart wear on the right. The axial flow tend to have a more linear HQ curve, whereas the centrifugals tend to have a more curvilinear HQ curve, and that again is related to the design of the pump. And again, just to reiterate, here we have the initial setting is at 9,000 RPM. If we bump it up to 10,000 RPM, the flow goes from 2 to 5 liters per minute. So just a redemonstration of that. Now we want to go kind of think about how changing the differential pressure affects the flow. So here we have an arbitrary setting of a map of 120, a mean LV pressure of 10, and a differential pressure of 110. This corresponds to a fairly low flow. Flow would be here. This you might understand to be a low flow alarm, for example, on a VAD. VADs are actually very, very afterload dependent, about 3 to 4 times more afterload dependent or afterload sensitive than the native heart itself. And you can imagine that this point, a map of 120 and mean LV pressure of 10, corresponding to, for example, a hypertensive VAD, a VAD patient who is excessive afterload and is having insufficient flow as a result. You can imagine taking this patient, putting him on nipride, and dropping the afterload, dropping the map to 120, narrowing or decreasing the delta pressure, the pressure differential, and having an improvement in flow. Basically dropping the afterload and riding the HQ curve up to a more normal flow. To kind of keep going with this, imagine being excessively afterload reduced. For example, vasoplegic in the setting of sepsis or adrenal insufficiency. Drop the preload more, the pressure differential drops again, and this time you have a very high flow, maybe even a supraphysiologic flow. So this is just kind of explaining how the flows relate to afterload manipulation. A similar relationship exists for preload dependence. So here we have another arbitrary point, a map of 90, mean LV pressure of 15, delta pressure of 75. And for example, the same patient gets over-diuresed, has a big GI bleed, or has decreased LV filling from tamponade or RV failure. The same kind of clinical situations create this type of physiology where the differential pressure falls and flow falls as a result. This is something to keep in mind when approaching LVAD patients with low flow alarms. Again, think about the pump afterload and pump preload when kind of approaching this type of patient at bedside. Again, low flow alarms are almost always a pressure differential event. There's a rare situation where you can have a complete pump thrombosis with no flow through the device, but that's a very, very rare event, very, very different from this situation. Again, this is just the differential. So use the HQ curve to inform your thinking about low flow alarms. Again, just to reiterate what I mentioned before, VADs are much more sensitive to afterload than the native heart, but also much less sensitive to preload. This works into how some LVAD patients have trouble with exercise. The preload should increase with exercise, but unfortunately, since they're a little less sensitive to preload, they're not able to mount appropriate flows. And unfortunately, without changing the RPM, they might fatigue easier, for example. The same HQ concept informs why durable VADs are less of a reality for patients. The idea is that there are several limitations to durable RVADs. One of them is a mechanical issue. The RV is more trabeculated. The tricuspid annulus is more apically located, so you could imagine a situation where there's worse TR or actual suck down on a trabeculum. These can be adjusted, though. The one thing that really makes durable RVADs difficult is the HQ curve. The idea is that the RV is it's a high volume, low pressure pump. The RV afterload is very, very low, much lower than LV afterload at baseline. And as a result, the position on the HQ curve is with a much smaller pressure differential. So at baseline, at what would be a normal operating RPM, the flow is very, very high. And you can imagine that someone who's anticoagulated and with a circulation that's not used to this type of flow, you can get pulmonary edema or even worse, pulmonary hemorrhage. So how do we adjust that? Again, think of keeping the pressure differential constant and dropping the RPMs. You could drop the RPMs, it would decrease the flow to a normal range. The problem, though, is that you'd be below the operating range for a lot of these pumps and increasing the risk of pump thrombosis. So that's not really an option. What typically is done in these types of patients is to bring the flow into a more normal range. Surgeons will actually try to increase the afterload of the RVAD, try to modify the outflow graft such that you create a stenosis, increase the RV afterload, increase the delta pressure, the pressure differential, and then bring the RVAD flow into a normal range without having to work at an unsafe VAD speed. So again, HQ curves inform why durable RVADs are not really an option in most patients. I want to address pump pulsatility really quickly as well. This is another kind of core concept, fundamental concept, and it also is informed by the HQ curve. So we talked a few minutes ago about how LVAD flows are determined by the pressure differential, pressure, the pump afterload, pump preload, and this may vary to a degree day to day with a magnitude that we're familiar with. The important thing is also that LVAD flows change second to second in accordance with the cardiac cycle. Small differences in pressure cause a reliable waveform change, a reliable change in the VAD flow that I'll show in a second. But this is another interesting concept. Just to reiterate, VAD flow is continuous, not constant. And as I mentioned earlier, VAD flow is coupled, albeit weakly, to native contractility. The VAD and the LV compete for preload, and depending on who's winning that competition, you'll either have increased pulsatility or decreased pulsatility. Now, mind you, this is not the presence or absence of a palpable pulse. That is a consequence of very, very high pulsatility or very, very low pulsatility. This is one of the variables that we see on the screen. So the HVAD console is on the top left, and you can see the flow waveform highlighted in red. That's the flow waveform. On the HeartMate 2, the pulse index is present in the top right, highlighted in red. Again, this is measuring the amplitude of flow. So the minimum flow compared to the maximum flow divided by the average. Both centrifugal and axial VADs have a similar flow waveform during the cardiac cycle. As we'll see in a second, the VAD flow is highest during systole and lowest during diastole, and I'll help kind of develop why that is the case. Why is there this phasic flow? Because there's a pressure differential that develops. So here we have a LV pressure tracing and an aortic pressure tracing. Again, think about it in terms of pump afterload and pump preload. You can see here during systole that the difference in pressure is small. The pressure differential here is much smaller than during diastole, say here. And again, keeping in mind the fact that pressure differential, or that flow is related inversely to pressure differential, you can kind of understand how these changes in pressure differential are driving flow changes throughout the cardiac cycle. And this just kind of highlights that fact. And you can see here the delta P, the pressure differential, changes systole to diastole. And again, the higher the pressure differential, the lower the flow. So this kind of helps bring it all together. We have here a waveform, a flow waveform on the bottom from the HVAD, and again, it matches what we were talking about. The larger the pressure differential, as occurs during diastole, the lower the flow. And you can see from end systole through diastole, there is a drop in flow in the LVAD. And this is a lower magnitude than what we see if you were to drop someone's LV filling pressure or dramatically increase someone's MAP, but this is present second to second within the VAD itself. And again, this is a similar representation, HQ curve, initial position during end systole, a pressure differential, say here. During diastole, again, the pressure difference increases, the differential pressure increases, flow decreases, and so basically during the cardiac cycle, you're bouncing between these 2 points. That's where the pulsatility comes from. This difference in flow, this amplitude, is what we're seeing on the flow waveform. This is probably best seen clinically in the inflow and outflow Dopplers. So this is the guideline paper by Dr. Estep, published when he was here, and we can see here the velocity profiles in systole and diastole. Now, or in the inflow cannula position and the outflow cannula position, and you can see here as well. Again, during systole, there is a rise in the velocity corresponding to a rise in VAD flow, and again, during diastole, there's a drop-off. This is the differential pressures what drives this flow that we see on echo. Another important concept is how pulsatility changes with RPM. So again, this is the HQ curve at different RPMs, and we represent here the flow on the bottom. So at 8,600, we have this position. At a set differential pressure, we have this flow, and a fairly large amplitude between systole and diastole. Cranking up the RPM, we notice that the flow amplitude diminishes. It becomes less pulsatile. This is ultimately what pulsatility looks like on the waveform. And at 9,600, it's barely pulsatile at all. So again, these are the initial positions at end systole on the curves. This is in diastole, and you can see here that the flow that the flow that the VAD generates during the cardiac cycle at high RPM is fairly small. There's a very small difference in flow corresponding to a small amplitude, whereas at a lower RPM, there's a larger flow difference and a larger amplitude. This is where pulsatility comes from. And again, the native LV and the LVAD are competing for inflow, or competing for preload. And this is what happens to the LV pressure waveform as you increase. As you ramp up the RPM, you get a decoupling of the LV pressure and the aortic pressure. The LV amplitude, or the LV pressure magnitude drops. The diastolic pressure rises somewhat, and the arterial waveform becomes attenuated and less pulsatile as well, because the preload that should be feeding the LV is driving into the pump itself. So when you see a flow that looks like this, you know that the pump is potentially going a little bit too fast. You've lost aortic valve opening, and you have insufficient pulsatility for that type of patient. Again, this is just reflecting this physiology using the HQ curve concepts. The delta pressure initially is very, very small in systole and rises and rises and rises throughout as you go up in RPM, causing a decrease in flow. So ultimately, the greater the pressure differential, the smaller the amplitude. And this is another echocardiographic example kind of demonstrating this. So this is at a lower RPM. This is the outflow Doppler CW. Fairly phasic, high systolic flow, and a fairly large amplitude. Going up on RPM, moving clockwise here, you go up on RPM, and here you can see the diastolic pressure rising, systolic pressure falling. At a high enough RPM, the amplitude is almost none, and you get oftentimes a very, very monotonous type of flow pattern. And pulsatility is what ends up driving that. So just to kind of finish up this concept really quickly, pulsatility is governed by VAD speed, native heart contractility, and then the pressure differential, and how these interact, as I was showing, explains how pulsatility works within the patient-pump relationship. Sometimes, if the magnitude changes enough, you will have a loss of a palpable pulse. At a constant pressure differential, the changes in VAD speed are inversely related to pump pulsatility. So going up on speed, like I said, drives down the pulsatility. And the other thing that's important, probably this is the most important concept of the pulsatility section, is the fact that increasing native contractility will increase pulsatility. So if you have a heart that is either recovering on the VAD, say, or appropriately afterload reduced, it'll have a little bit better contractility, higher stroke volume crossing the valve, and that'll be reflected in waveform pulsatility. So this just kind of highlights some examples of how this would look like. You could have a change in native contractility from beta blocker titration, inotrope manipulation, or even exercise. Just to jump through this section, there is an optimal VAD flow setting that takes pulsatility into account. You want some valve opening driven by pulsatility. You want a midline interventricular septum. You want as normalized a chamber dimension as you can get on both sides of the heart, and you want as minimal MR as possible. And keeping the HQ concepts in mind while doing this will help allow you to get the best flow possible. The last topic I wanted to very, very quickly go through is power consumption. So pump power is located here on the HeartMate 2 console. And an important thing to understand is that the LVAD devices don't have flow sensors. There had been some work earlier on to try to put flow sensors within VADs. The problem, though, is that the flow sensors drift. They tend to have they tend to become a little less reliable over time. So instead of trying to work with VAD data, VAD engineers decided to eliminate a flow sensor entirely. There's something worse than, the only thing worse than no data is bad data. So the flow sensor was eliminated. And the lucky thing is that while a VAD flow is not something that can be directly measured, pump power is linearly related to flow. This is the linear equation relating VAD flow to power. And what's very, very nice, what's useful for us as clinicians is the fact that going up on power, which is the product of current and voltage, will go up linearly with flow. So if the pump power is low, that means that the flow is low. If the pump power is noted to be high, that means the VAD flow is high. So while we cannot directly know pump flows, looking at pump power will allow us to get a handle on that physiology. And these are just the HP curves, just showing the linear relationship. The H is, of course, the pressure differential, and the P is the power. So you can see here for the hardware HVAD device, as power goes up, flow goes up. So that just reiterates and documents or shows us that using power estimating flow using power is reliable. Just a couple conclusions for us. I wanted to introduce HQ curves as a way to understand VAD physiology and as a way to approach kind of a complicated VAD patient, looking at pump preload and pump afterload and that relationship in terms of evaluating flows, especially low flow alarms, which can be a little bit more difficult to troubleshoot. Pulsatility is a very important part of a patient's hemodynamic fingerprint, and changes from baseline, in a patient's pulsatility from baseline may be one of the first signs that contractility is changing, that delta pressure is changing. So there's that. Thank you, everyone.
Thank you, Paul. That was fantastic. I certainly learned something. We have a couple minutes for questions, so we'll pass the mic around. First question to you, aortic insufficiency, which is, we certainly see in VAD populations. Conceptually, it's both a decrease in afterload and potentially an increase in preload. How do you factor that into these curves?
So that is very, very interesting. There really hasn't been all that much HQ curve work about this, and it makes how can I put this? It changes two things at once. It changes the pump afterload and it changes the pump preload. It creates overcirculation. I wish I had a better answer for how specifically it changes the HQ curve. It can only be all I can do is guess at this point.
Paul, that was very nice. Actually, never thought about it as much as you're thinking about it. And I think it can help us also understand the flow dynamics that we see non-invasively with Doppler and other things. One thing I still don't understand well, I don't know if you can explain it, simple question, maybe still difficult, is if I have this, what is the mechanism of change in flow with delta P? Meaning, if this pump is flowing at 9,600, let's say, right, RPM, and if I increase systolic pressure by, let's say, 20 millimeters of mercury, is this pump becoming less efficient? Does it slow down because of the afterload is higher? I mean, what decreases the flow with that delta P? Or do you have more volume in the outflow graft? I'm just not understanding still why on a constant RPM, right, and you still, the ventricle is filling, although its pressure is maybe a little different. What decreases the flow?
So ultimately, the question as I understand it is how does changing an afterload actually
Understanding the HQ curve is,
and as it turns out, power does increase somewhat, but it cannot increase to the point where it is it can compensate fully. There's actually some algorithms that are being developed. There was a paper, I forget exactly where it was from, that is trying to build in physiologic changes in RPM to increase flow in situations where a patient should need it.
so with more resistance, do you think the RPM goes down a bit than the labeled 9600? I'm just trying to understand what makes the flow less.
I think you can phone a friend now, right?
Yes.
Let's see.
Bill, you would be like being in a boat with an outboard motor, and you're going at the same speed, but the river current going against you is higher. The boat's not going to be able to go as fast. It's a similar concept. It's because the speed of the centrifugal pump doesn't change. It's just the forces against it. As they go up, the flow has to go down.
So the power consumption.
You could compensate by making your motor go faster, but these pumps are set right or wrong in a fixed speed. They don't yet have I mean, there is the technology available for an automatic mode that will sense this, but they're not really in application right now.
Thank you, everyone.
Paul, you're officially off the hook. Well done. Well done. Thank you, sir. All right, our next defendant. So it's my pleasure to introduce Maan Malahfji. Maan is a native of Syria, went to Aleppo Medical School, did internal medicine residency at the University of Texas at Houston, and then fellowship here, of course. We've been privileged to have him in the valve clinic with us for the last year. So after this year, thankfully, no more questions from Maan. But he's clearly got an interest in cardiomyopathy and valvular heart disease, and we're thrilled that he's going to stay on with us in July for an advanced imaging fellowship. So over to you, Maan.
Just what I thought I understood LVADs. Thank you, Paul. That was awesome. My talk will be slightly different and slightly shorter as well. The title of the talk is Creativity in Cardiovascular Medicine and Some Historical Lessons. A few people that I want to bring up. Dr. Jokadar is a cardiologist in Emory, and he really has been an inspiration to me. I did a rotation with him as a medical student. He has less popular interests than what's really interesting these days, things like the physical exam and the humanities in medicine, and he inspired many parts of this talk. Dr. Forster has written an amazing book called Heart Healers, and that's also been the source of a lot of this material. I think if you combine that book along with Dr. Winter's book, you probably get a 360-degree view of cardiology and CV surgery over the past 70 years. And then Dr. Hill is the chairman of medicine at UT Southwestern. He visited with us a few months ago and gave excellent grand rounds, much better than mine. And he told us a story over lunch. I asked him how he ended up becoming the editor of Circulation. And he said that he had a sponsor. That's the term that he used. And it's kind of a degree beyond a mentor. And it's actually this guy, and that's a young Dr. Braunwald. And the editor of Circulation position wasn't anywhere on his radar, but he got a call from Dr. Braunwald, and he was like, hey, there's this position, you should apply for it. And that's how we became editor of Circulation. And that got me thinking, we have had a lot of mentors and sponsors in this institution. And I was like, okay, well, let me try to name them. Dr. Pratt, I wouldn't be here if it wasn't for his determination. Dr. Quinones, Dr. Zogby, Dr. Little, Dr. Shah, the other Dr. Shah, Dr. Mamarian. And you see where I'm going with this. All of you guys have been excellent mentors and sponsors, and it's been a privilege to train with you. And here's the giants, and here are the group of fellows standing on the shoulders of giants. So I really would like to get a round of applause from all the fellows for all of you guys for putting up with us the past 3 years. Now, and another quick note, and the images don't really project well, but that's not the point. We had a great Grand Rounds lecture by Dr. Berlocker last week. And there's one other piece about education that I think has been amazing here, and I've never really experienced that very often elsewhere. And this is, I think, what fellowship is about. You know, as she mentioned, it's self-driven, but also you need some people to kind of sit down with you and carry you over a certain problem. So here's Dr. Naga. This was probably 8:30 p.m. on a Thursday evening, Echo Lab, and we just went over the derivation of the tau constant of relaxation. And here's Dr. Lowry. This is in between operations in the old Fondren OR in the lounge. We were just going over complex mitral valve anatomy. And then Dr. Zogby, this is a little bit later, probably around 9:30 p.m. or so, in the Echo Lab. And you know, you really don't get the stuff anywhere else. And it's been amazing. So thank you guys for that. Now I want to bring up 3 patients to try to go over how cardiovascular care has changed over the year and how our view of heart health has been. So here's FDR. FDR was a chain smoker, and it was the year 1945. He had severe uncontrolled hypertension. He had heart failure. He had what seemed like recurrent episodes of pulmonary edema, and he was very ill. His physician at the time was an Admiral, Dr. McIntyre, and he was an ENT specialist. We examined him, he assessed him, and he had to travel across the world to meet with Churchill and Stalin. And his prescription was a cigarette and a massage, and they gave him 2 hours each day for rest. And unfortunately, you know, he died 2 months afterwards of a brain hemorrhage. And that was all we had in terms of cardiac care at the time. LBJ, also 3 packs a day. He had a myocardial infarction before he was president, and he had stopped smoking, so there's already some progression. People, you know, started recognizing that things weren't as healthy. And after he was done with his presidency, he got back into smoking and gained a lot of weight out here in his ranch in Texas, and unfortunately had 2 other MIs, and also passed away early. And at the time, all of our care for MI was just bed rest, as far as I was aware of. President Bush, in contrast, lived to his 90s, and he had some cardiac illness. You know, he had a syncopal event while playing golf, and he was found to have AFib. And as you all know, a cardiologist that took care of him, an excellent man, our own Dr. Haskenek. So I'll tell you 3 stories about the history of cardiology and CV surgery, and I'll try to glean a few lessons from them that I learned and hopefully you'll think are useful. So we'll begin with 2 surgeons and 2 cardiologists. One of them kind of got in the way of the surgeon, and the other one helped him out. And we'll discuss Dr. Harken first. He was born in Iowa. He was an intern in Bellevue Hospital. He made $15 a month. This was at the time of the Great Depression. Did some further training in London and went back to Harvard to work there. But then World War II broke, and he enlisted and was in the London 160th General Hospital. And he was only 35 at the time. And he became famous for being able to operate in the chest and near the heart without losing soldiers. And there was 134 that he was able to remove shrapnel from. Shrapnel at the time was a deadly fragment and still is. And he was able to treat all of these soldiers successfully. And Harken was kind of the larger-than-life typical surgeon. You know, a lot of him reminds me of Dr. Reardon. He always thought that he was right. He was very pleasant. He was, he would never, He never admit defeat. But also on the other end, and that's not really like Dr. Reardon, you know, he could go from being very pleasant and very nice and be, you know, wreak havoc on trainees in the OR, and they called him the Great Red Man. You don't have that feature, but he would turn red when he would when he would become argumentative. And his competitor. We should probably never had that interaction. So Dr. Bailey was his competitor at the time, and you see he made the Time magazine cover. Born the same year, he had a kind of personal history with mitral stenosis, and mitral stenosis is the theme of this story, really the most deadly valvular heart disease at the time. And he trained in Hahnemann, later became chief of surgery there. And he was a little bit different. He was aggressive and confrontational. He wasn't as kind of larger and very sophisticated, if you will, as Harken, but he was his equal in ambition and confidence and his drive to innovate. So are those two the actual surgeons that were the true pioneers of operating on the heart? And remember, this time we didn't have any bypass machine. So Dr. Ludwig-Wren was actually able to repair a lacerated RV more than 50 years earlier. Dr. Cutler in 1924 was able to actually treat mitral stenosis with this device called the valvulotome, but the patient ended up with severe MR, and he never really kind of carried that further. Same thing for Dr. Sotar, and you know, you can tell that they already had the idea and they already had the drive and success, but they just never really carried it as well. And here's a little note that Dr. Harken sent his wife, and I want to drive your attention to how he tried to remove shrapnel from this soldier. The fragment jumped out of the ventricle, blood poured out. I took large needles wedged with silk, and the silk part here was really what did the trick. And he started passing them through, and he would drive the sutures through the heart during diastole, as opposed to systole, where systole would essentially result in a lot of tearing. And at the end of the suturing, he kind of accidentally sutured his glove to the heart and had to cut out the glove. And you know, it was a success, but just not a perfect. So here's, yeah, well, who else is he gonna tell? So here's their race to try to operate on mitral stenosis, no bypass. So Bailey's first case, he put a clamp on the left atrial appendage. Their plan was to cut the left atrium, tamponade the bleed, and kind of wedge their finger in there, try to split out the commissures, and very quickly, as they withdraw their finger, their assistants would kind of tighten up the sutures that they already had in there, and voila, you close the left atrium. And that didn't work as well. So second case, he had a little metal device that didn't work, patient died. And you know, this is within seconds, obviously, so he was called Butcher Bailey. And here's the cardiologist that kind of got in his way, and Bailey recollects that he ended up telling me it was my Christian duty to keep you from doing any of these homicidal procedures. And Bailey, in classic Bailey fashion, responded, I was like, I believe in this operation, and I'm sure that I'm right, and it is my Christian duty to continue. So we shook hands, and I departed. And as you can expect, his privileges were suspended soon after. So he tried a third patient, another hospital in Pennsylvania. Patient dies of MR. And then the fourth patient was really unstable even before he started. So his physician was like, you know, I really want you to operate on this guy. And Bailey, fearing that this will become his fourth mortality, hesitated. But then he was like, well, if you declare him dead because he's so unstable, I'll just operate on him and it won't be my fault. So his physician declared him dead. and they did the operation, and the patient didn't survive. And the fifth patient finally was a success. And he used a combination of kind of splitting the commissure with his fingers and so on and so forth. So here's Harken's story. Same thing, he was trying the same stuff, very similar techniques around the same time. 6 out of 6 patients died. And he had a different source of trouble, his own personal guilt, because he was like, well, I can't keep doing this to patients, and all these people are dying. And he was like, well, consulting with a cardiologist, he's like, I don't think any respectable physician would send me a patient And Ellis and the Brigham was like, well, I'm generally considered respectable. I'm the president of the New England Cardiac Society, and I'll send you another patient. And just in the classic surgical referral, I would never send you a patient who wasn't dying anyway. So, if you try again, I'll send you a patient. So Harken keeps trying, and he finally does successful. He calls it a valvuloplasty. Harken calls it a commissurotomy. And he does it, but only 5 days later. So what can we learn from this? Is it true that these two individuals achieved success kind of all of a sudden or out of nothing? And I'm sure many of you had read Gladwell's book. It's not really that. Harken, for example, he's been practicing for this for many years. Before he enlisted and went to London, he had been working in the animal lab and he would put dirty safety pins in dogs' hearts and try to extract them successfully without killing the dogs. And this is how success is achieved. You train and you practice and you work on things for years before this happened, and it doesn't really come from nothing. And credit goes to people who convince the world, not the people with the first idea. We learn more from our failures, and as always, the best answers lead to new questions. I'll go a little bit quicker. So the next frontier was surgical treatment of heart failure. And we have these two individuals here. Dr. Starr, he was in his 30s. He had just gone to Oregon, and they lured him to start a CV surgery program there, and they really wanted him to go salmon fishing. Well, he was intrigued by that idea. And then you have Lowell Edwards here, who's semi-retired. He was in his 60s, as opposed to him being in his 30s. And they decided to go ahead and try to address heart failure. And Lowell wanted to create a machinery like heart. He wanted to get into the VAD game, essentially. And Starr thought that it was too early and that we still need valve replacement, that we can't really just jump too far ahead, if you will. And this is the treatment we had for heart failure at the time. We had digoxin. And this is Van Gogh's, who was reportedly on digoxin. This is his portrait of his own physician. And people say that he uses a lot of yellow because he had dig toxicity. And these two people with very different experiences came together and combined their expertise to try to create a valve. Now, there were multiple other people who actually had done valves and have been working on this. So the patent of the bottle stopper, 1858, inspires this ball and cage design, and a German surgeon by the name of Hufnagel implants this successfully in the descending aorta. He initially used a plexiglass cage, and it was made out of a silicone-coated nylon puppet. And the silicone coating happened a little bit later. When he didn't use the silicone, the valve was so loud that people can hear it from across the room. So we ended up using the silicone to make it a little quieter, but people can still hear it. And then Chesterman of England also tried to make a prosthetic mitral valve, but the patient didn't survive. And there's so many questions when you're trying to design and work on a valve. Can you simplify the mitral valve complex structure? What type of material should we use? Should we try to follow the function of the valve, or should we try to make it in the way nature has made it? And this can take years to answer, but these two guys took the concepts and the design and the testing and the implementation within 2 years. And it was really remarkable. Imagine trying to do that now. So their first design, they actually tried to follow form. They made a Teflon kind of cross with a ring, and they tried to make leaflets similar to the person's own leaflets, but the dogs would die within days, and the valve would clot. Their second design, which Starr called a repugnant intercardiac appliance, used the cage with the ball, and they later added on this shield that prevented a lot of the clotting, especially in dogs who have a more active coagulation system than humans. And with the addition of this design, they were able to achieve more than 80% long-term survival. And the chief of cardiology, who was walking by the dogs that are clicking away in their lab, sees the opportunity and starts sending them his terminal patients. So this is the first operation that they did. They were able to successfully replace the valve. They used actually the older generation of their design, and the patient did okay initially. It was a young lady in her 20s, and as soon as, this is an x-ray similar to the x-ray that she would have, and they saw this air in the pericardium, and they thought that it was benign and there's nothing really to worry about, it'll just resolve. But as the patient later that night gets up out of bed in the ICU, or, well, they did have an ICU at the time, she suddenly collapses and dies. And it turns out that she had an air embolism, unfortunately. That didn't deter them. They kept going, and their first-year operative mortality was 50%, but 5 years later, that was reduced to less than 10%. And what can we learn from Starr and Edwards? Well, you have to collaborate. You can't just keep doing things by yourself. You should collaborate with, collaborate with those that are at least, likely to be collaboration candidates, if you will, and try to draw inspiration from your competition then, and don't be afraid to try. And then if you fail greatly, you will at some point achieve greatly as well. This is the machinery they use to test the valve. This could kind of achieve 40 years simulation of valve function by making the valve beat for 1,000 times a minute or whatever. And persistence is key. Now, I will go into my last story, and no history talk wouldn't be complete without a mention of the percutaneous gurus. So we have Dr. Daughter, who was born in Boston and studied in Cornell. Also went to what later became OHSU, and he was chairman of radiology there at the age of 32. This is his associate/fellow, Dr. Judkins, and he creates the catheters that we use to this day, also trained with Dr. Soanes. And this is Dr. Sellinger, a Swede who invented the technique we use every day back in the 50s. And Dr. Daughter had discovered that you can, and it was a kind of serendipity where he accidentally discovered that you can deflect atheroma and move it away. And he used pre-shaped catheter, or he used catheters that were gradually dilated, and he tried to, and he was successful in opening up this person's SFA, for example. He was a very avid fan of climbing, and he took the patient with him, and they took the summit. The patient, who was near getting an amputation, kept reminding her surgeon that I still have 2 legs, no thanks to you. And Dr. Daughter became very famous, and surgeons, would send him these referrals, do an angio, please, visualize, but do not try to fix. And that brings us to Dr. Grunzig, who was born in Dresden. We all know what happened 5 years later, and he moved out and went to medical school in Heidelberg. Also trained in radiology. He saw a description of the Daughter technique and all the daughtering we do today, and he realized that, hey, I want to do this again. But he had his eyes set on the coronaries as well. And he caused some embolic phenomena sometimes, and there was some conflict with his chairman of radiology at the time. And his solution to that was just transferring himself to cardiology. Try to do that these days. And this is Grunzig's, 5 years, I would say. This is the poster that he presented in AHA in the 70s, and so many people walked by, and Spencer King, who would become his partner and associate, had mentioned that he walked by it and didn't ever think that it would work. And this is how they worked on the catheters. This is his assistant, and this is her husband, and you can see they're having a good old time with all the balloons that they were trying to create in material. And this took 3 years. It wasn't, an easy, design to create. And I wanted to bring this up. This is his first patient. Everyone shows the angiograms, but see how Grunzig also revolutionized and really initiated physiology as well. And he shows you how the PDPA changes after he treated the coronary stenosis. And we all know about his patient. So what can we learn from Grunzig? And I will say, probably the most critical achievement, and as we all know, he died at a really young age, unfortunately, but he shared his knowledge and he shared his discovery. He didn't really try to make it his thing, and he would hold all of these symposiums. Dr. Soanes was in the audience here, Dr. Daughter was here as well, and Dr. Judkins as well. And he would have these courses and teach people and try to teach people angioplasty. And he really wanted the technique to succeed. It wasn't about him. And he shared the credit with all those that worked with him. And as we all know, he also was one of those larger-than-life individuals, the life of the party, and he always had a good time. So he had his own plane, he had a Porsche, and never really deviated from having a good time. And I'll leave you with a final note, and this is going back to Dr. Harken. One thing that's, we see often at the end of the late-breaking sessions that everyone thanks the patients, but we have to bring up patients back then in the 50s and the 60s who really literally put their lives on the line for procedures that were never done on anyone else. So this is one of Harken's patients, and she didn't make it. She had written this note and gave it to a neighbor or friend who later gave it to him. And as I mentioned, Harken felt really guilty about all of the patients that he lost. But she said, thanks for the chance. A small portion of my estate has been left to see that this doesn't happen again. And we really have to thank all the patients that trust us in doing what we do and putting their lives and their livelihoods at risk with us trying to achieve something. So thank you.
Thanks. Thank you, Maan. That was a great tour de force and overview. It was really enjoyable, particularly the pre-op death certificates. I think we have to revisit that sometimes. Questions, comments?
That's one thing to be careful about with pre-op death. So I have a friend that will go unnamed in California who, this many years ago, somebody was at the cath lab getting a PCI and they occluded the artery and arrested. And they brought him down to the room pumping on him, and the surgeon operated on the guy. And when the guy died, as they often did when they come down that way, and he was so mad when he dictated the operative report, he wrote, "This guy came to the OR dead. I operated on him, and he stayed dead." And the California refused to pay him because they won't pay for operating on dead people. So be careful how you do this. I think the other great lesson is Grunswick certainly was larger than life, but the lesson is doctors should not own airplanes.
That's true. Yeah, we know that from Dr. Pacifico as well.
Yeah. Dr. Z, here you go.
I think this was wonderful, and I want to compliment both of you for such amazing presentations that gives us different perspectives. Yes, we invite amazing speakers from throughout the country and the world, and our own faculty. But I want to say that this series of our graduating fellows is phenomenal, is stellar. Actually, we're in awe as to what you bring to the table. And I think the future of cardiology is really very bright. Thank you very much.
Thank you. Thank you. Stealing a lot of tricks from